This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, in this video I'll be sharing a case wherein we have an elderly male patient with a very dense cataract, pseudoexfoliation, non-dilating pupil, question mark zonular weakness, and how do we plan our surgery in such cases and also implement them, and what are the complications which we can anticipate and plan accordingly. These are some of the things which I'll be discussing as we go along this case, and also sharing few tips on the use of iris hooks. So to begin with, let's list out the challenges which we can anticipate in this case. The visualization would be poor because of the small pupil. We have got a very dense cataract to deal with. The chamber is not very deep. It's about 2.6. And the corneal health will also be a cause for concern as is an elderly patient, as would be the zonular health. And the complication rate is significantly higher. And the most dreaded one, that is the posterior capsular tear. It is relatively common in these eyes because the amount of force which is required to divide this hard nucleus is going to put some pressure on the posterior capsule and the zonules, and that's the reason why we have increased risk of capsulozonular complications in these eyes. So let's try to plan and try to minimize the risks at every step of the surgery. So this would be my plan. To deal with the pupil, I'm going to use iris hooks for a change because this gives me a wider expansion of the pupil, and because I'm dealing with a denser nucleus, I intend to have a very large rhexis. This also helps in minimizing any complications during nucleus maneuvering. And for safety options, I'm going to use a scleral tunnel incision rather than a clear corneal incision. Two things: it also minimizes the potential risk of a wound burn, which is very rare when using a torsional energy. Apart from that, it also gives me an easy way out to extend the incision if I decide to convert to a manual small incision cataract surgery in the eventuality of a intraoperative difficulty. So with that plan in mind, I'm beginning to make a small scleral tunnel incision after doing a peritomy. The scleral groove is made about 1.5 mm posterior to the limbus. I'm going to create a sclerocorneal tunnel using a crescent knife, and the intracorneal tunnel is going to be at least about 1.5 mm into the cornea. Now for the iris hooks, I'm going to create 4 ports for introducing the iris hooks. One important tip for creating these ports for iris hooks would be the ports are more like a stab incision. They are starting from the posterior limbus. They don't have a long corneal valve, and it's more like a direct stab incision. This helps in easier maneuvering of the iris hooks into the eye and also while removing, and a posterior incision helps us to prevent the tenting up of the iris. I've also stained the blade with trypan blue so that I can identify the location quite easily. So I made 3 incisions for the iris hook itself. I'm going to introduce the iris hooks now one by one. It is going to hook the pupillary margin. At this stage, I'm not going to pull the iris hooks. It is just engaging and the pupil is just a bit pulled. It's not totally pulled towards the periphery. Simple reason is I'd want to do it only when the 4th is done. 4th iris hook is going to be behind the scleral tunnel incision. It's about 0.5 mm posterior to the scleral groove which we have done. And through that, I'm going to introduce the 4th iris hook. And once all the 4 iris hooks are in place, now is the time I'm going to stretch the pupil so that I have a decent exposure of the underlying lens. So I made 2 more side port incisions for my bimanual I&A. The area of the capsule which was left unstained because of small pupil, I tried to restain it using the trypan blue, just trying to paint it across the surface of the anterior capsule. Now because it's already got in touch with the OVD, it won't take up the stain very well, but still something is better than nothing. With the chamber being inflated with OVD, I'm entering the main sclerocorneal tunnel with my 2.8 mm sharp keratome. So I can see that the wound construction is pretty good, and let's begin with the rhexis. At this point I realized that the staining of the peripheral capsule is not so great, so I just want to restain it. I'm going in with my irrigation cannula to just irrigate out all the OVD which would be sticking in the antechamber and on the anterocapsule. So once I feel that the OVD is been taken off, I'm going to refill the chamber with air followed by trypan blue. The staining is pretty good now, and time to do the rexus. The chamber is refilled with OVD. Because I'm expecting some amount of zonular weakness, I'm going to puncture the capsule using a sharp 26 number needle rather than my forceps. So as I puncture the capsule, it lifts up quite easily. There's no wrinkling of the anticapsule, suggesting the zonular health could be alright. I go in with my forceps and begin doing the rexus. My goal is to have quite a large rexus in view of the underlying big hard nucleus. So I'm aiming about 5.5 to 6 millimeter rexus, and the way the capsule is steering, it looks like the zonules are alright. So until now, the things are going as per plan. So we have a good visualization because the iris hooks, and we also have a decent sized rexus, which should make nucleus management relatively safe. So as has been my preferred choice of late, I'm going to use the classical divide and conquer 4-quadrant technique for managing the nucleus. The nucleus is stabilized with my second instrument, and I begin doing a long central trench using just the torsional energy. I'd just like to talk about the settings here. When we're sculpting, we don't require much of a flow rate and the vacuum. They're very low. And I'm consciously using torsional energy because of its exceptional cutting ability compared to the longitudinal version. And the advantage is the amount of heat which is generated is also relatively less. So we've got great cutting ability without having any heat generation. So with this cutting power, we can, melt most of the cataracts quite effortlessly. As the trenching is being done, you can notice that the nucleus is not being pushed at or shoved at. The nucleus is just being melted as the probe progresses from the subincisional area to the other end. So these are tough cases and hard cataracts. We need to be very patient and be as slow and steady as possible, trying to create as deep a trench as possible here. My goal is to create at least 85 to 90% depth up to the posterior plate. The nucleus is being rotated and subsequently the 4 grooves are being deepened. So while rotating the nucleus, I usually prefer to use the bimanual way of rotation. That's I'm using both the phaco tip and the dialer to rotate the nucleus. This technique of using both these instruments helps us to rotate the nucleus using very minimal force and making it act very efficiently. This minimizes any risk of inducing any sort of zonular stress while we are maneuvering the nucleus. Once I feel that the depth of these trenches is deep enough, I'm going to switch to the chop mode where I'm going to bury my phaco tip in one of the lateral walls of these fragments and then perform the lateral separation maneuver. So this is sort of a modification of your conventional chop, but we already created a groove and then we're burying the phaco tip into the substance of the nucleus and then doing lateral separation. So this is relatively much more beneficial when you're dealing with harder cataracts like this because we can firmly hold one part and then do the lateral separations. Again, mind you, when I'm doing these chop maneuvers, I'm using the longitudinal energy, which gives better grip and we don't end up creating a hole and lose the grip. And some of the fragments are quite huge, so I'm going to divide them subsequently into 2 halves by using the vertical chop technique. The tip is buried into the substance of the nucleus, the chopper goes down vertically and then laterally. So now the entire huge nucleus is broken down into smaller fragments. We have got about 5 fragments now, and then each of these fragments is now being pulled out of the bag and then emulsified at the level of the rexus margin or the iris. Once the first couple of fragments are emulsified, it's important to go and replenish the OVD back in. The dispersive OVD goes in first under the cornea and below it goes the HPMC, and as I've been talking of in many of my previous videos, this is the modified soft shell technique combination which I prefer to use. Simply because the HPMC is much less thermogenic when the energy is being delivered. Whereas the dispersive OVD, if it is there in the vicinity of the phaco tip, it can get clogged into the tip and that can cause rise in temperature. So that's the reason why we want to use it near the endothelium and the HPMC, which is very less viscous, doesn't clog the tip, and the risk of heat generation is very minimal. So all the fragments are emulsified. Time to deal with the epinucleus in the cortex. I'm using bimanual irrigation aspiration to remove all the cortical matter. The chamber is refilled with OVD. The planned single-piece hydrophobic lens is gently maneuvered into the bag. A fringe of cortex is remaining, which is aspirated out. The OVD both in front and behind the lens is irrigated out. Time to remove the iris hooks. Because the OVD has already been removed out, I want to refill the chamber with a little bit of OVD, and then each of these iris hooks is disengaged from the pupillary margin and gently slid out. Now this iris was very light and thin iris, and we can see these multiple atrophic holes in the iris. Well, that is to be expected when we are stretching the iris. And also in the subincisional area, maybe the phaco tip would have touched upon the iris and exacerbating this the amount of atrophic holes which you're seeing. All the side port incisions and the paracentesis for iris hooks are hydrated. The conjunctiva is closed and the intracameral antibiotics are placed into the eye. That's it, the case is done. Now these are the third day post-op pictures. There is some corneal edema, but eventually it clears off and the patient is reasonably happy. Few lessons from this case. If you're really well prepared for a tough case, most often than not, the complications which anticipated would never happen because you already figured out how to prevent it. And even in the case if it does happen, you are mentally very well prepared to handle it. So being prepared is the key, and with the knowledge and experience which we have, we can anticipate few things in most case scenarios and plan accordingly. So that was it. Thank you for watching and hope you found this helpful.